Hey guys, and welcome back to Clinical Physio with me, Phil Richards. In today's video, we're going to be talking about testing active range of motion of the shoulder joint. We're going to be taking you through the key movements you need to do and also the key muscles that are involved in those actions. If you're not familiar with why we test active range of motion, we suggest you check out our video titled Why We Test Active Range of Motion for the full clinical reasoning process behind why we do what we do. Also, in the next video, we're not going to be comparing the affected and unaffected sides, just because we don't want to slow your video down. But of course, in practice, we always want you to compare the affected and unaffected to see if there's any differences from left to right. So when we're thinking about testing active range of motion, we need to consider three things: P, Q, and R, and that stands for pain, quality, and range. If you're familiar with our P, Q, and R, you can head straight onto the next video and we'll see you there. If you're not familiar with our P, Q, and R, here's a recap.
So as we have said, when testing active range of movement of any joint, we need to consider P, Q, and R. P for pain, Q for quality of movement, and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not elicited as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology, or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement, and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to know the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measured the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement.
So shoulder flexion. So all we do is we have our patients sat. You of course can stand them up, just to bear in mind the variances and how postures can change and create more space. We're going to do our sitting. So from here, we ask our model to straighten their elbow, have their thumb pointing up towards the ceiling and to lift it up as far as they can go. From here, we're going to add our overpressure. So we're going to have one hand on the humerus like so. The other hand is going to support on the back of the scapula, and we're going to just guide them a bit further so we can appreciate an end feel. And so when we're thinking about the muscles that initiate and carry through that shoulder flexion, we want to be thinking of the anterior deltoid, the clavicular fibers of pec major, coracobrachialis, and the long head of biceps will act as a shoulder flexor also. But just as important will be the activation and contraction of the rotator cuff muscles to ensure that the glenohumeral head stays perfectly in that glenoid fossa throughout that movement. So let's talk about our P, Q, and R, so pain, quality, and range. Well, we've already said that pain is a really tricky one with this one. So it could be a bursa problem, we could have a rotator cuff problem, we could pick any number of problems. We could still get a pain referral anterior, posterior, lateral, or on the top. And this could refer as far down to the wrist and hand if we're affecting the dermatome too. So the skin that innervates from those different nerve roots can also transmit that pain, which is normally going to be a dull diffuse ache down that arm. So what do we do with that? Well, there's one thing we can point out from the pain location, which can give us an idea, and that's if it's right on the ACJ. That would give us a really good clue straight away that we may have an arthritic change here or a bony spur here. But other than that, most of the other pathologies, the pain location doesn't tell us that much, as frustrating as it seems. So let's rush on to Q for quality. because that can tell us. If we think of a rotator cuff problem, if it's significant enough and it's torn, you may find that they're not actually able to lift their arm up. And they say, oh yeah, I found I can't really lift my arm up anymore, but if I pick the other hand up with it, it goes really far. So the quality of movement in that case would say, wow, that looks like a very significant rotator cuff tear. So that's one. If we think of something arthritic, then in terms of the quality, it may actually be quite good, but they're kind of getting a bit stuck a bit early on, and it kind of hurts a lot more towards the end. That sort of gives potentially an idea of this grumbly, older shoulder, and that's an arthritic change. If we're thinking like the frozen shoulder type presentation, and it's gone far enough in, we're going to see this kind of lifting action in terms of the quality, where the rotator cuff is so jammed up with all the capsule tightness that they've got no freedom to move within this joint, so they're just going to be hiking here. So that's another quality we can use to help our clinical diagnosis. And finally, let's talk about the range. So we're expecting the range to be around 165 degrees, which is going to look like basically they can point their fingers to the top. Now, if we talk through those pathologies again, so if it's a rotator cuff tear, we said, well, they probably won't get that much range if it's significant enough, potentially. If it's osteoarthritis, they might get a bit less than that because it's a bit jammed. If it's a frozen shoulder and it's far enough in, we're really going to be struggling, but not through a lack of will. It's just going to look effortful from here. So now we're going to test active range of movement into shoulder abduction, abduction. So as a therapist, we're going to stand behind our patient. The reason we want to do that is not only can we see the arm and how much abduction is being achieved, but we get a good look at the scapula and also anything involved in the posterior chain, scoliosis, hip hike, etc. Of course, if anything piques your interest, you can always look laterally and anteriorly as you wish to. We've chosen the sitting position today. You could, of course, do it in standing. You just need to bear in mind different ways people can adapt and cheat and move when they're standing relative to sitting. But you can always compare the two again, or just stick with one. Your findings will guide you as you go. Let's get back on task. So how are we going to achieve this? We ask the patient with their thumb facing outwards, with an elbow straight, to lift it as high up as they can so that they're trying to get their arm to touch their ear. From here, we're going to add our overpressure. And we can put one hand on the opposite shoulder for comfort, and we can use the other hand on the side, the lateral aspect of the humerus, and just press and compress it a bit further. We can come back down from there. So let's think about the chief muscles involved in AB, abduction, the glenohumeral joint. Well, our main ones we're going to think about are the middle deltoid and the rotator cuff acting as a dynamic stabilizer. Now, classically, especially when we were being taught in university, they would talk about supraspinatus being involved in the first 30 degrees or so of the abduction movement. But we know more and more, as more research is done and the more EMG studies are done, that they think that's not actually the case, and that supraspinatus, although will principally abduct on an EMG study, when you put it together with an actual human being, the supraspinatus, along with the other rotator cuff muscles, are more a dynamic stabilizer and that guide as the shoulder's moving. So it's best to think of it that way. Now, also we have to take into account the scapula. So as well as thinking of the middle deltoid and the rotator cuff, you also want to bear in mind the contributors from, say, the upper trapezius muscle and serratus anterior in particular, because if those guys aren't working, chances are your abduction's not going to be very good. So let's think about our P, Q, and R, so pain, quality, and range. We've talked before about the pain referral of the shoulder, and it can be all over the place, anterior, lateral, posterior, up, radiating up, and we've got the crossover with the neck. But when we think about trying to keep it simple again, and we think something like a rotator cuff, that could be pretty much anywhere in and around the shoulder and down. Our osteoarthritis, the same story. But if it's particularly an ACJ problem, then the pain location can be quite specific and local. And they might say, oh yeah, it comes down my arm, but it's really bad in particular there. That's a good clue. Also with our frozen shoulder, that pain can just radiate down as well. So only particularly with the ACJ is the pain location particularly helpful. With quality, so let's go through that. So if we think of the rotator cuff issue, well, if we've got a significant tear, we're going to have a situation where they can't really lift out very much at all. And again, they might have this situation where they can lift it up a lot easier with their other hand, or you might find that they've got into this habit where they fling it up and do something. So that would be a big clue in terms of the quality. If we're thinking of something like a frozen shoulder, we may have this real sort of hitching up because they've lost so much joint motion because the capsule's gone so tight. And then if we're thinking of a grumbly OA shoulder, which is just generalized wear and tear, you may find that they can get kind of so far, but they just don't really like it, and they might only get sort of thus far. They won't necessarily be able to get full range, and there'll be kind of a mixed picture throughout. And you'll look for other classic signs like their age and general loss of movement, and these other signs to sort of fit that osteoarthritic pathology. So I wanted to draw your attention to a couple of things you may find with shoulder abduction. The first one is when you've asked them to abduct their shoulder, they've kind of gone into a more of a flexed position here. And then when you think about it, you ask them to do shoulder flexion, and it wasn't a pure flexion here, it was kind of abducted. And then you may be thinking, oh, well, that's a coincidence, but chances are it's not a coincidence. And this is the most comfortable range your patient can find. Now the reason is because the glenoid fossa, so where this humeral bone goes, is it's not perfectly aligned this way or this way. It sits kind of angled, which means this line here, which they call scaption, is the line where you're going to have the most smooth, free articulation of lifting the arm up, which means that when you come up into flexion, you are actually going to be slightly compressing the joint because it's angled. And likewise, if you come purely out to the side in abduction, you're going to be compressing that. So that would give you a big clue that perhaps I'm dealing with a generalized grotty, restricted shoulder, and the reason they've chosen to lift up is because that's the best way they can achieve movement. So if you do find that in clinic, just make sure you retest them properly so you can gather more accurate data. Now the second one that we find with abduction is that they've gone into a lot of shoulder extension when they try and lift up. And what they've done here is they've lifted back like that, and they've lifted up and they go, yeah, it pinches. Well, the thing is that pinches a lot of people that are non-symptomatic anyway. So just make sure that you make that correction, and certainly if you give out abduction as a rehab exercise, to make sure that they're not excessively extending, because chances are you're going to cause more irritation than good. And finally, the range for shoulder abduction is 170 degrees. So now we're going to test active range of movement of the glenohumeral joint into external rotation or lateral rotation. They're the same thing. So as the therapist, we're going to stand on the same side of the shoulder we're testing. And our patient can be either in a sitting or standing position. Because of the way you may need to block the patient's movement, depending on how well they can move, you may prefer standing over sitting because you've got more control. And I'll explain in a second why. So what do? Well, we ask the patient to bend their elbow up, so we've got a 90 degrees elbow flexion position. From here we say, keep your elbow into your side and then bring your knuckles out as far as you can to touch my hand. And you can guide them into the external rotation and say, keep going as far as you can. So that's our active movement. Now we need our overpressure. So there's a few variations here. One, you can cup the elbow joint posteriorly with this hand, and the other hand can come onto the inside of the wrist, and you can guide it further here. Another variation is you can just use your forearm a bit more, so you've got a little bit more control of the scapula here. You can come through. And another variation, which is the one I personally use in clinic a lot, is I will just grasp lightly on the opposite shoulder and pull my hip in here so I can actually block there. So you've got a choice. But again, the principle is we control the arm and then we can bring it a little bit further into lateral rotation so we can complete our overpressure. So let's think about the key muscles that are involved in this. Well, we want to be thinking about teres minor. We want to think about the posterior deltoid, and we also want to think about the infraspinatus. Now, at the moment, there is evidence to suggest that supraspinatus can also be involved in creating the lateral rotation movement. Personally, we would recommend that for the time being you bear that in mind, but principally still think of the teres minor, the infraspinatus and the posterior deltoid carrying out this work. So let's talk about P, Q and R, so pain, quality and range. As with a lot of shoulder pain, we can get a lot of referral anterior, lateral, and posterior. And we're very unlikely to get our classic ACJ specific pain unless it's very, very, very hyperacute, because we're not really stressing the ACJ particularly at this point. What we are going to stress is the following. So if we have a significant enough rotator cuff problem, then this action is going to be quite sore and painful, and they might not even, if it's really torn, they may not even be able to do it. You're going to see this kind of awkward kind of turn, and this is going to show up later in your resisted test even more. The other main thing is going to be to do with a capsular tightness in the shoulder joint here, which could be due to something like a frozen shoulder, or it could be a stiffness secondary to a fracture that could cause a capsular tightness, or it could be a younger person who just happens to have developed a capsular tightness. It doesn't have to be exclusive in the older population group. But as we're coming across this way, the anterior capsule is going to be more and more stretched. So if there's any sign of compression or irritation, this is likely to refer pain. And it may not be specifically on one side, or as we've talked about before, it could be just kind of through the shoulder, just saying, just kind of rages through. We don't have a specific pain referral pattern for a capsular issue. So that's in terms of the pain. So just to recap, we're thinking rotator cuff could irritate it because it has to drive the lateral rotation. We're not thinking impingement because there's not really an impingement occurring in the subacromial space. We're thinking about something to do with a capsular pattern involvement, the anterior capsule, which could be from a frozen shoulder or general tightness. They're the key ones. Now, in terms of quality, so if they have a significant tear, as we spoke about at the rotator cuff, they may not be able to do it at all, as we spoke about. But the other one you're going to see a lot is when the restriction is so great, what they end up doing is they kind of abduct and extend their arm and go, look, I'm doing it. And it kind of looks like this, rather than this definitive lateral rotation. Now, it could be a technique issue, so you can guide them through it, but you're probably going to find that actually it's because they're so restricted up here that that's the best they can do. And if you do go on to do something like a capsular stretch out like here, they call them sleeper stretches, you want to make sure that they don't end up doing this cheat, thinking they've progressed when they haven't. So really make sure it's a pure movement if you're including that in your rehab program. And then also something I wanted to talk about with the range. So the range, if we're in this position, is documented to be around 100 degrees. And this is an alternative testing position, which we'll talk about in a second. With regards to here, the best way of thinking about it is that it can come to a 90-degree angle, taking into account scapular adduction. So at the moment, we're about so, we could say around 70 degrees. By the time I support in here, and even if I block, it's going to come nicely out to about there. So that's where you're expecting. If you're getting to about here, and that's as far as you can go, that would probably give you a good indication of a capsular restriction, particularly for a frozen shoulder. So let's talk about the range with respect to posterior muscle dysfunction. So something you're going to find if rhomboids aren't firing, if the posterior deltoid's not firing very well, is when they actively bring their arm out, they're not going to get very far. So just because I'm interested, if we get Polly to see how far she can bring her arm out, then that looks perfect. What you may find in clinic is they come out to about here, and that's as far as they can get. But by the time you add the overpressure on, you're like, oh, that's strange. And what can happen is if you have dysfunction in the posterior muscles, they, due to the hypertonicity and the way they don't coordinate very well, they kind of jam themselves. So the overpressure is a really nice way to see, is this like a muscle imbalance, or actually is this a tightness issue? So that's something else to look for. Going back to this alternative position, some clinicians will test this routinely. It's not routine to the examination to test lateral rotation in this position. And of course, you could do this in standing, or if you prefer, supine, where you can get more control of what's going on. A good time to use it is if this is clear and you're struggling to find objective measures in your examination. And you want to see what's happening, particularly when you can isolate the glenohumeral joint a lot more. The other thing it's good for is isolating the joint capsule, so you can see, do they have a true capsular tightness, or do we have just an issue with the cumbersomeness that can come with this testing position? But as a recap, if we're looking purely from the glenohumeral joint and externally rotating, we want around 100 degrees. So now we're going to test active range of movement of the glenohumeral joint into internal rotation or medial rotation as the same term. So as a therapist, we're going to stand beside the patient. Our patient is going to be stood. From here, we ask them to see how far they can put their hand up their back. And you can just do a little sort of demonstration. Say, how far can you get your hand behind your back? So we ask our patient to do that. And if we just get Polly to turn round, we can see from here. Now, often you don't need to add overpressure in this situation, but of course you're welcome to. If you did want to, it's literally a very, very small guide further up into the position. You don't necessarily need to go any further than that. If you wanted to, you can always see if there's a gap that you can fit your fingers behind and gently draw back this way to see if there's more of a capsular tightness. But please be careful not to provocate too much pain because it's quite a sensitive position if someone's come to you with shoulder pain. So when we're thinking about the chief muscles that are involved in this, we want to think of the subscapularis as a powerful medial rotator. We want to think of the rotator cuff working to provide the dynamic stability with the movement anyhow. We want to think about the pec major being involved and the lat dorsi, and the lat dorsi's little helper, teres major, also will be involved, as well as the anterior fibers of the deltoid that are all going to pull it round into that position. Now also you can test this with the patient standing or supine without the hand behind back component. It's an internal rotation component at the 90 degrees shoulder flexion. So if we just get Polly to spin back round, we can lift the arm and abduct it to that 90 degrees there. From here we can drop the wrist in. Now one of the issues is in standing is they can kind of move around and get away from it. So if that's the case and you're trying to provide your gentle overpressure here, which we can do nicely from the wrist and the elbow, and they're moving around a bit too much, it's very uncomfortable, you can always isolate it better with them supine on the bed. So let's think about our P, Q and R, so pain, quality and range of this internal rotation. So when we're thinking about pain, because we're moving quite a lot of structures around within the shoulder, we can have a lot of pain from different structures, right? And we can have referral anterior, lateral, posterior, or through the shoulder, or referred through the skin. So the presence of pain itself is not necessarily that helpful. But there's a couple of things we're looking at and we're thinking about. And one is a frozen shoulder and one is a capsular tightness. And what happens with our quality and range is going to point us in that direction. We're thinking less about an ACJ issue because we're not causing that much ACJ spinning, gliding, and compression. So that brings us to the quality. So one of the main things you're going to see with a capsular tightness, a frozen shoulder, is this big kind of hunching protraction or this really awkward movement to try and desperately get this wrist up behind their back. And we're going to see it's really cumbersome. Or they've got to do this thing where they kind of plant their wrist and then they're kind of either going to try and pull it through with the other finger or they're going to try and work the arm up. They're going to be things you see time and time again, and that's going to point you in this direction. And that brings us nicely onto the range. So when someone has a capsular restriction, if we just turn Polly around, the variance where we'd see restriction will be anywhere from here in extreme cases where they just can't get their hand behind their back, but even anywhere up to say sort of L5 we would still consider to be tight. You want really to be able to get to roughly sort of T12 upwards depending on the natural flexibility of the person. And then you might be thinking at home, well, which bits get into T12? And that's exactly what you need to note down. So some clinicians like to point to where the thumb can get to. Other clinicians will do the little finger. I personally go generally with the wrist. So I will write hand behind back, patient can get wrist to X level. And that will be what I include in my notation. So we've got an idea of the range relative to that motion. If we just get Paul to turn round. Now, similarly from the external rotation, we can test internal rotation at 90 degrees abduction, where we can bring the wrist in this way. And again, we can have our hand position to provide overpressure. just bear in mind that it will be more cumbersome stood up and you may prefer to do it supine. From this position, the expected range is going to be 70 degrees. But if we're thinking they've got a capsular restriction, again, it's going to be a lot less than that. And regardless of whether you're pushing on the glenohumeral head or whatnot, you're going to find it still jammed because that posterior capsule is so tight. Another thing, just while it's sprung to mind, that might cause a restriction in the quality and the movement is a muscle imbalance or a glenohumeral head instability. So if you think when we try and do this movement here, the head of the humerus has to be dynamically stabilized to perfectly spin to achieve that. If we think of an instability and the head can come forwards, it's going to jam up. But that doesn't have to be just from an instability, it can be from an imbalance, something from the front to pulling too hard or from the back. So that's another consideration to throw into the mix. So just a quick note when testing active range of motion of the shoulder joint. You could also include adduction and extension, but they're not routinely covered in the examination. If you wanted to include these, you'd have something in your subjective or objective findings that would suggest you would go to there. For instance, if they said, well, it comes on when I reach across for something, and everything else is quite fine, but every time I come across, then of course you'd ask them to reach across to see what's happening. Or you found during your examination they have pain localized to their ACJ and you're pushing the ACJ and that's bringing on their symptoms. You could complete something like a SCARF test, which is a special test which could include provocation signs for the ACJ to further support your hypothesis. Or for instance, you suspect there's an issue with the anterior capsule and you want to see if that's involved when they actively extend their arm. Perhaps they were bowling and they got pain coming back here. Those sorts of things will guide you there. So once you've done your initial examination, don't feel caged by it. Feel free to explore off of it. That's your prerogative as an autonomous practitioner. So if you find that you're like, well, what happens if we turn the thumb out? Does that affect the impingement? Or what happens actually if we ask to reach a bit more across? Of course, you can go into that detail and you may find some really interesting findings to support your normal objective examination. So please go there if you need to. Active range of movement, shoulder summary. Start your active range of movement assessment by clearing the neck. Then complete your assessment of active range of movement of the patient's shoulder by looking at active flexion, abduction, internal rotation, external rotation, and extension. Adduction may be included, but is not routine to the examination. Make yourself familiar with the different patient and therapist positions and the method of applying overpressure, as well as the muscles involved in the movement. When looking at active range of movement, look for P, Q, and R. Pain, quality of movement, and range of movement. And that concludes our video on testing active range of motion of the shoulder joint. From here, we'd like you to go on and test passive range of motion of the shoulder joint. And by comparing the two, you can see if it's more likely a contractile or non-contractile lesion is responsible for your patient's condition. This, alongside your other tests, will inform your patient diagnosis. If you're not familiar with why we test active range of motion and passive range of motion, please check out our videos titled Why Test Active Range of Motion and Why Test Passive Range of Motion. Thanks so much for watching, guys. We'll see you again soon on Clinical Physio.